It has long been perceived by researchers as well as planners of India that there is a widening gap in the quality and access to healthcare between rural and urban areas of the country. While more than 70% of India's population reside in villages, there is a centralization of healthcare amenities in towns and cities. Ground realities in the villages indicate that despite increasing structural presence of the formal public healthcare system in the rural areas, people largely depend on health workers that have been variously termed as unqualified, RMPs, quacks, etc. These rural healthcare providers, RHCP, are mostly village youths who take to the profession of providing curative care to the village residents based on the experience gained while working as chamber assistant to doctors in nearby urban locations. Others simply try to learn the tricks of the trade by closely following prescriptions of doctors for some time. The rural healthcare providers are self-employed and entrepreneurial health workers who have not undergone any formal training to do so. Liver Foundation West Bengal's endeavor and engagement in RHCP research, supported by NRHM, Department of Health and Family Welfare, Government of West Bengal, and Bristol Myers Squibb Foundation, New York, had been engaged in a capacity building intervention involving some selected RHCPs in Birbhum, Murshidabad, Purulia, Nadia, and Sundarban areas of West Bengal. This had been a structured program where the RHCPs are taught through classroom and demonstration classes, focusing on what not to do and what to do to save lives, improve referrals to mainstream system in time, and also to use them for public health campaigns. One of the driving intents of the program also had been to convert a group of self-proclaimed doctors into a clan of enriched healthcare workers.
Over the last decade or so, what we have seen is, after proper training and enrichment, these rural healthcare human resources could be used for an excellent tool for reaching out to a larger segment of rural folks for the emerging non-communicable diseases issues. We have seen that they can be useful in improving awareness, in taking NCD to the doorstep, and also in providing initial primary care in NCDs, like taking blood pressure, testing for blood sugar, telling them when to take drugs and all. In addition to this NCD usage, what we have found is they can be a useful tool for National Tuberculosis Control Program also. I mean, the most remote part of the healthcare delivery system, because all our rural healthcare delivery formal system people in the villages are possibly overburdened, ashas I mean. And if these informal providers could be envisioned as a group of people who are the remotest arms, not within the system but very tightly linked to the system, which can take us to the villagers given the fact of their proximity with the villagers, then I think the information of the system could be taken to the people. So what we have found is they can be a very useful tool for improving outcomes of the National Tuberculosis Control Program, even picking up the defaulters in not only tuberculosis, for leprosy also, and we have experimented with them and we found that they are excellent healthcare human resource for picking up defaulters in leprosy and tuberculosis.
Further, to get potential outcomes, rural healthcare providers need a continuous support system. So Liver Foundation West Bengal and Raksha Health made an app which is known as Decision Support System. Decision Support System is mainly meant to assist healthcare providers with decision making in cases with complications.
In the past, India never had enough doctors to take care of our population, and in the future we probably never will too. The reason is that it costs a lot to train a doctor and we are a poor country. So what can make a difference? Nowadays, computers with artificial intelligence distributed on a mobile platform can support contextually specific clinical decisions that are personalized for a patient, and they can do that in rural and underserved areas. We are building a system that improves healthcare quality by improving clinical decisions with artificial intelligence at the very periphery for the rural and the underserved.
Arnab Chattoraj is a RHCP. He is from Purulia district. He is practicing allopathic medicine since 2000, and the distance of his village from the district headquarters is only 7 kilometers.
লিভার ফাউন্ডেশন অফিস থেকে 2006-07 ট্রেনিং নিই আমি 9 মাসের যে ট্রেনিং ছিল সেটা আমি নিয়েছি, সেটা নিয়ে অনেকটাই উপকৃত হয়েছি। লিভার ফাউন্ডেশন পশ্চিমবঙ্গ এবং রাক্সা গ্রুপ ডিএসএস যে ইয়াটা আছে সেটা ব্যবহার করছি আমি। ব্যবহার করার পরে আমাদের অনেকটাই লাভ হচ্ছে এবং কোথায় কী ধরনের চিকিৎসা হচ্ছে, কে কী করছে, কী ওষুধ দিচ্ছে না, সেটা আমাদের ভালোই কাজ হচ্ছে।
Tarun Chakraborty is also RHCP, and he is practicing more than 28 years. The distance of his village from Kolkata, the capital, is about 50 kilometers.
প্রশিক্ষণের ফলে আমাদের অনেক জিনিস জানা ছিল না, সেগুলো স্যারেদের কাছে প্রশ্ন করে আমরা জানতে পারছি, বা প্র্যাকটিস করতে গিয়ে যে সমস্ত প্রবলেমগুলো আমাদের হচ্ছে সেগুলো স্যারেদের কাছে আমরা প্রশ্ন করে জেনে নিতে পারছি আর কি। আমি স্বাস্থ্যকর্মী হিসেবেই ভাবি, কখনো তো চিকিৎসক নয়, কারণ চিকিৎসক হতে গেলে তাদের যে একটা প্রশিক্ষণ থাকে সেই সব প্রশিক্ষণ তো আমরা পাইনি, তা সুতরাং আমরা স্বাস্থ্যকর্মী। হ্যাঁ, এটাতে আমরা বিশেষ করে খুবই উপকৃত হচ্ছি, কারণ যখন পেশেন্টের একটা মেডিসিন আমরা সিলেক্ট করছি সেখানে অনেক মেডিসিন আমাদের জানা নেই, সেগুলো পরপর একটা সার্চ লিস্ট অনুযায়ী চলে আসছে, সেখান থেকে আমরা কিছু মেডিসিন সংক্রান্ত ব্যাপারে যেমন জানতে পারছি, তেমন পেশেন্টের ডিজিজ যখন আমরা লিখছি যেটা এই ডিজিজ হয়েছে তার রিলেটেড আর কি আছে সেগুলো আসছে। সুতরাং এটা খুব একটা ভালো জিনিস, আর এটা চাই এটা হোক বা আরও যাতে উন্নত হয় সেই জিনিসটা দেখতে হবে।
Liver Foundation West Bengal has been engaged in research exploring utility and strength of alternative healthcare human resource, including untrained providers of the informal sector where there is no doctor.